Implementation of time-restricted eating in individuals with type 2 diabetes requires careful consideration of glycemic safety alongside potential metabolic benefits. Pilot trials incorporating continuous glucose monitoring and clinician-supervised medication management provide essential safety data for this vulnerable population. 8-week interventions comparing isocaloric time-restricted eating to usual care reveal a nuanced safety profile demanding individualized assessment and monitoring protocols rather than blanket recommendations. The most significant safety concern involves hypoglycemia risk, particularly in individuals using insulin or sulfonylureas with glucose-dependent dosing requirements. Compressing eating into narrower windows alters the timing of carbohydrate availability relative to medication action profiles, potentially creating mismatches that precipitate dangerous glucose nadirs. Continuous glucose monitoring data from early trials documented hypoglycemic episodes below 70 milligrams per deciliter in approximately 15 to 25% of participants during initial weeks before medication adjustments occurred. However, with proactive medication titration based on real-time glucose patterns, hypoglycemia rates declined to levels comparable to control groups by week 4. This observation underscores that time-restricted eating can be implemented safely in type 2 diabetes, but requires active clinical oversight rather than patient-directed adoption. When calories are reduced alongside eating window compression, some participants demonstrate meaningful improvements in glycemic control. Time and range metrics from continuous glucose monitoring show increases of 5 to 12 percentage points in individuals achieving moderate calorie deficits, with corresponding reductions in glycated hemoglobin averaging 0.3 to 0.6 percentage points over 8 weeks. These improvements align with expected benefits from equivalent weight loss achieved through other dietary approaches, again suggesting that calorie reduction rather than meal timing drives glycemic improvements. Interestingly, some individuals show reduced glucose variability even when calories remain matched, possibly reflecting improved circadian alignment of insulin sensitivity with nutrient availability, though this effect appears modest and inconsistent across participants. Clinical implementation requires structured protocols including baseline glucose pattern assessment, medication review with adjustment planning, patient education about hypoglycemia recognition and management, and frequent early monitoring with glucose data review. Individuals on insulin require particularly close supervision with potential basal insulin reduction by 10 to 20% at intervention initiation, with subsequent adjustments based on observed patterns. The intervention shows promise for select motivated patients with type 2 diabetes when implemented with appropriate safeguards, but remains inappropriate for unsupervised adoption. Clinicians should view time-restricted eating as one possible tool within comprehensive diabetes management rather than a standalone intervention, recognizing that traditional approaches, including medical nutrition therapy, physical activity, and optimized pharmacotherapy, retain primacy. Future research should identify which diabetes phenotypes derive the greatest benefit with the most favorable safety profile, enabling more precise patient selection and counseling.